Hello, everyone. Welcome to this Hyperfine webinar with ASNR. We're just letting everyone into the room right now. Zoom seems to let people in one at a time, just like a doorway. So we'll just give it a moment and then we'll get started. Thanks for joining us today. Hi, everyone. Thanks for your patience. Thanks for joining us today. Looks like we have quite a few attendees here, so we will go ahead and get started in the interest of time. So welcome to today's webinar. This is Industry Innovates, hosted by Hyperfine, point of care MRI in your hospital-based neuroradiology practice. Our presenter today is Dr. Edmond Knopp, and our moderator is Dr. Michael Brandt-Sawatsky, and I'll introduce them in just a moment. So we're using Zoom today. You can use the Q&A panel to ask questions of the presenters, and that will follow the presentation. You can also use the chat box to discuss and connect with the attendees and the presenters. And we'll be here live in the session to answer any questions. If you don't want to see these notifications, you can minimize the chat box in your Zoom control panel. We'd love for you to connect with ASNR. These are our various social channels. And it would also be great if you would like to connect with Hyperfine. You can connect through the website, LinkedIn, or Twitter. So now I'll take a moment and introduce our presenters for today. Dr. Edmond Knopp joined Hyperfine Research in January 2021 as the Senior Medical Director. Dr. Knopp has nearly 3 decades of clinical care and research experience in radiology, neuroradiology, and MR imaging, and is widely recognized as a pioneer in the field for his numerous accomplishments and thought leadership. In his role with Hyperfine, Dr. Knopp will work to establish a clinical center of excellence, develop the company's overarching clinical and medical strategies, and will serve as Hyperfine's representative to the clinical community, fostering relationships with key opinion leaders on a global basis. His experience and expertise supports Hyperfine's ongoing commitment to understanding the clinical issues facing the healthcare delivery community and continues to influence products that are on the cutting edge of innovation and superior patient care. Dr. Knopp is a senior member of the American Society of Neuroradiology and an American Board of Radiology examiner, and sits on the editorial boards of many of the industry's leading peer-reviewed publications. He was awarded the American Board of Radiology's Lifetime Service Award in 2015. He serves as an advisor to the International Diagnostic Course in Davos, which is the largest medical imaging training course in the world. He's the author of over 80 publications and has given hundreds of international and national presentations. Dr. Knopp has over 26 years experience in academia and private practice, including serving on the faculty at the New York University School of Medicine for more than 20 years. While at NYU, Dr. Knopp held multiple roles, including Director of Neuroradiology, Director of MRI Education, and most recently, Associate Chairman for Quality, Technology, and Safety. Dr. Knopp is a graduate of Emory University and received his medical doctorate from the State University of New York Health Sciences University College of Medicine. He was a surgical resident for 2 years, followed by a radiology residency, and finally a 2-year neuroradiology fellowship. Thank you for joining us, Dr. Knopp. And now I'll introduce Dr. Brandt-Sawatsky, who is the Senior Physician Executive at Hoag Hospital, facilitating business relationships with specialist clinicians, overseeing programmatic care that integrates specialized services with population health. He helps Hoag transform healthcare strategy by focusing on specific health conditions using a program-driven, physician-led, multidisciplinary team approach, measured by patient-focused outcomes. He also oversees the Hoag Center for Research and Education. He holds the Ron and Sandy Simon Endowed Chair as the Executive Medical Director of the Pickup Family Neurosciences Institute at Hoag, having led the Institute from its inception. The Institute coordinates neurosurgery, neurology, psychiatry, pain, addiction, and sleep services, and it ranks in the top 1% nationally for neurology and neurosurgery services per U.S. News and World Report. Dr. Brandt-Sawatsky has a BA from Stanford and an MD from the University of Cincinnati, where he graduated first in his class. His training in diagnostic radiology and in interventional neuroradiology were both at Stanford. He spent 6 years in the Department of Radiology at UCSF and still holds an adjunct professorship at Stanford. Dr. Brandt-Sawatsky has authored over 250 papers, numerous textbooks, serves on a variety of editorial boards for professional journals, and sat on numerous professional organization boards and committees. He lectures internationally and nationally, and he is a fellow of the American College of Radiology and a recipient of gold medals from the Society of Magnetic Resonance in Medicine and the American Society of Neuroradiology. He was medical director of radiology at Hoag, earned the Certificate of Leadership for Healthcare Transformation from UC Irvine's Paul Merage School of Business. He is a founder of and consultant to a number of companies in the biotech and radiology fields. So I'd like to welcome Dr. Brant Sawatsky, who will get us started today. Thank you both for being here.
Thank you. You're muted, BZ.
Thank you very much. A pleasure to be here. I don't know who that introduction was for, but wherever I go, that person seems to show up. My sense is, though, if it weren't for me, he wouldn't be here. So we're both here, and Ed is kind enough to invite me to moderate. Full disclosure, I am an advisor to the company, and in that vein, I also want to say, however, that I would not have become an advisor had I not found the value proposition you're about to hear about from Ed compelling. So Eddie, it's yours.
Thank you very much, BZ. So with that, let me share my screen and we'll get started. So thank you everyone for joining. And this afternoon, I'd like to discuss point of care MRI in your hospital-based neuroradiologic practice. First, I'd like to give a quick overview of Hyperfine, kind of history and vision, and basically the mission of the company itself. Hyperfine was founded by Jonathan Rothberg, a PhD geneticist out of Yale. And basically the mission of Hyperfine and other of Jonathan Rothberg's 4 catalyzer companies is to provide a means of affordable and accessible imaging, sensing, and guided robotic intervention to revolutionize healthcare for people around the world. And we do have systems globally around the world, approximately 60 at this time. What we feel is that Hyperfine has created the next generation of MR. Some of you may recall MRI 1.0, or as I'm labeling it, back in the 1980s, which does not look anything like it looks now, but everyone is now more familiar with MRI 2.0, which exploded in the 90s, kind of along the McDonald's supersize era, where the advent of 1.5 and 3 Tesla whole body high resolution images came out. And now we would like to discuss what we're calling our MRI 3.0, which is our portable point of care Hyperfine system. And I'd like to show you just a brief overview for those who may not be familiar with the system. It's about a 1-minute video that'll show you the portability and mobility of the system itself. So as I mentioned, we feel that we've created the next generation of MR, and that's possible through our patent-protected noise cancellation systems that enables this portable low-field MR to exist and provide diagnostic quality imaging anywhere it's placed. It's FDA cleared and was cleared back in 2020. Reimbursement is utilizing existing CPT codes, specifically 70551, which is MRI brain without contrast. Currently, we have an installed base of approximately 60 units globally, and there are primary clinical uses. I want to emphasize this is not a replacement for your high field scanners, be they 1.5, be they 3T or 7T, but rather a means to answer specific clinical questions in situations and scenarios where that may be too difficult, if not impossible, in the setting of acute mental status change, hydrocephalus, maybe cerebral trauma, as well as stroke. So let's look at what are the potential benefits to the various stakeholders in an institution where Hyperfine can help. Clearly, first and foremost is the patient. For the patient, we see the benefits is safer than transporting that sick, unstable, ventilated ICU patient down to the main MR suite. That affords a greater degree of comfort and convenience, and ultimately faster diagnosis with improved quality of patient care. What about for the physician? We can expedite the time from diagnosis and treatment by bringing the MR to the patient rather than bringing the patient to the scanner and trying to fit them in to an already full MR schedule. By expediting that time, hopefully we can discharge patients sooner, either from the ICU or from the hospital. For the staff, the benefit to the staff is a better incorporation into workflow, reducing that patient transport, reducing that risk. The system is ergonomic, intuitive, and user-friendly. And what about to the care center itself, the academic institution, the private hospital, whatever it is? We can potentially reduce complication rates. Again, we're not transporting that patient. We can have improved utilization of various resources, and potentially, depending on the financial structure of the imaging center, increased revenue or allow for potential earlier discharge and decreased length of stay. Realize when transporting a patient from an ICU, say, down to the main MR facility, you're going to have to block that scanner for an hour and a half and not be able to scan 3, 4, or maybe 5 patients during that one time interval. If you eliminate that step, you can increase your throughput. Now, there are numerous challenges with traditional MR. We all know high cost limits accessibility, complex siting requirements as well. Scheduling delays can lead to a longer length of stay. If you're trying to squeeze the patient into an already overpacked schedule, that's going to be somewhat problematic. You have to use and take personal resources from one place to another. The nursing staff, the respiratory therapy staff would have to leave the ICU to accompany the sick, unstable patient. And during that time, there's always the risk of an adverse event occurring during transportation. Reportedly, anywhere from 25 to 50% of time, that can happen. There are significant workflow benefits. This is data from a large academic medical center on the West Coast, where basically the time in an ICU setting for traditional MRI workflow is about a day from the time that the exam is ordered to the time that it's actually performed. All sorts of delays, the patient's unstable, can't come down to MRI now, MRI can't accommodate them and the like. Whereas if we bring that scanner to the patient in the ICU, we can eliminate that 25 hours time, bring it down to 90 minutes, almost a 95% reduction in that total workflow time. And again, we address all of the challenges of traditional MR by bringing the scanner to the patient instead of the patient to the scanner. That can be in the emergency room, that can be in the ER, it can even be in the operating room, not operating within the scanner, but providing immediate postoperative guidance for those patients, as well as global health, because the system can plug into any 15 amp outlet and exist in any environment. It can exist anywhere, basically, in the world that has electricity. So what are our potential clinical use cases? And we can break them down by the primary sites that are utilized. First and foremost, as I see it, is the intensive care unit. And of the list here, again, I think the most significant is the acute mental status change in that ICU patient. It's 2 o'clock in the morning, the patient is post-op, they were supposed to wake up and they haven't. What's going on? What are our options? We can try to transport that patient down to MR if it's available 24/7 to find out, or we can bring the scanner to the patient to try to find out what's going on. Is there acute obstructive hydrocephalus? Is there a large extraaxial collection, intraparenchymal hemorrhage, and the like? And likewise, you can see all of these diagnoses can lead to therapeutic effect. So if we can find that there's acute obstructive hydrocephalus, we can place an EVD, maybe even using image guidance. The sequences are 3D and can be fused into neuronavigation systems. If we see an intraparenchymal hemorrhage or a stroke, it can be treated accordingly. Whoops, wrong way. And the same holds for the emergency room. We can use it as our decision maker. our triage device in the emergency room when the patient comes in to determine how am I going to dispose of this patient in the emergency setting. Do they have to be admitted to the hospital for treatment or observation, or can they be discharged, worked up on the outside for subsequent evaluation? Clearly, time saving in the ER, decreasing the amount of time that patients have to board waiting for a conventional MR. Likewise, in a rehabilitation clinic, it gives us the ability to follow patients more closely. If they have an acute stroke and they're not doing the way that we would expect them to, we can image them at their point of care to determine, is that infarct progressing or not? Likewise, in an outpatient setting, and maybe even more so in the pediatric setting, pediatric hydrocephalus. We can image children with potential shunt failures at the point of care, in the neurosurgeon's office, in the emergency room, make a quick determination in 2.5 to 3 minutes. Are the ventricles big? Are they not big? Do I need to admit this patient for a shunt revision? So let's discuss some individual value propositions. First and foremost, as I mentioned, is acute mental status change in an ICU for the most part, or basically anywhere in the hospital. And these are opinions of Dr. Fadi Charbel, the neurosurgery chairman at University of Illinois, Chicago, and Dan Chow, one of our neuroradiologic colleagues at UC Irvine. Basically, they're looking at the use of the system in patients with mental status change to eliminate or reduce the extent of patient transport to MR, and therefore the associated potential adverse events associated with that transport. They're seeing cost reductions that are associated with changing staffing requirements and patient transport. They can maintain staffing levels in the ICU. If you're transporting a patient from the ICU down to MR, you're pulling an ICU nurse, maybe you're pulling a respiratory therapist, you're pulling a transporter. By not being able to do that, the nursing staff and the respiratory therapy staff can stay where they are and treat additional patients. You can see potential revenue increases associated with increases in your high field conventional MRI outpatient capacity growth if you're using systems for both in and outpatients, or decreasing the length of stay either in the ICU or the hospital by making things more efficient and increasing throughput both in the ICU on portable imaging as well as on the conventional scanners by not delaying those scanners themselves. Here's a treatment algorithm for a patient with an acute mental status change in the ICU. We would bring the scanner up to the patient. Sorry about that. This mouse is crazy. We bring the scanner up to the patient and do a bedside evaluation looking at conventional imaging, T1, T2, and FLAIR. All that can be obtained 3D fashion in any orthogonal plane. If those are negative, we would then go on to diffusion weighted imaging, a B0, a B900, and an ADC, and make an assessment. If that's positive, you're going to treat the patient for stroke. If the conventional imaging, the T1, the T2, and the FLAIR are grossly positive, assess what the abnormality is. Is there intraventricular hemorrhage? Is there hydrocephalus? Well, place an EVD in the ICU. Is it a postoperative patient? Is there intraparenchymal hemorrhage? Is there an extraaxial collection? Well, treat that accordingly. So we're using the bedside MRI to make diagnosis and treatment decisions at the point of care. And here are just a couple of examples. In this example is an elderly patient following cardiac surgery on cardiopulmonary bypass, so they were fully anticoagulated, did not wake up in the ICU in the expected time. Brain Swoop image was put in, a large intraparenchymal hemorrhage was noted, patient was transferred to the operating room for decompression. Likewise, another patient with a known left-sided hemispheric infarct is progressing. Patient is unstable. They don't want to send that patient down to the main MR facility. They obtained the portable Swoop scan, shows new ongoing ischemia. Patient was then treated for additional new acute infarct. So Hyperfine, as you would imagine, provides a compelling platform for stroke diagnosis. We all know the significant problem with stroke, 15 million patients worldwide, second leading cause of death globally. Hyperfine can provides an affordable MR platform that can provide diffusion-weighted imaging for stroke diagnosis at the patient's bedside. We can look at the Hyperfine images, in particular looking at diffusion and FLAIR, and looking for that diffusion-FLAIR mismatch, especially in the setting of wake-up stroke scenario, to make treatment decisions. Can we perform thrombectomy or maybe even potentially increase the thrombolysis window? And these value propositions are being looked at by some of our clinical collaborators, Dr. Shai Nimji from Ohio State and Chuck Stout from HCA Riverside, looking specifically can either in the emergency room or at an additional point of care, and Shai has a scanner in his angio room as well, to reduce the time to clinical diagnosis, decision-making and diagnosis, eliminating that wait for high field MR if that's necessary, potentially eliminating CT and clearly the additional CT dye load in these patients that maybe have renal insufficiency to start, enabling more potential life-saving decisions much quicker, with the end result in faster diagnosis and improved patient outcome. Just a little movie example of acute infarct. On our images, we can see flare, the B900 DWI, the corresponding ADC, and the T2. You'll also note on the flare and the T2 weighted images, the ventricular systems are color-coded because we also have FDA approved volumetric analysis of the ventricular system to get automated calculations of ventricular volume, change in ventricular volume, and midline shift.
Eddie, how old is that infarct?
How old is this? This is a subacute infarct with some ongoing ischemia based on the appearance. So looking at another treatment algorithm in the setting of the emergency room and possible stroke, patient would present. I don't think we're ever going to get away from easy bread and butter non-contrast CT. If it's positive, subarach, you're going to treat that patient for subarachnoid hemorrhage. If it's negative for blood, then depending on how aggressive you want to be, and there are variable schools of thought in this, work the patient up with CT, make determinations based on that. If you're still unsure or time is greater than 6 hours from last well known, let's get a bedside MRI, not affecting our main MR system, look for a diffusion flare mismatch. If there is no diffusion flare mismatch, we can observe and follow up that patient. If there is diffusion flare mismatch, i.e. there is brain at risk and ischemic penumbra, and there's no large vessel occlusion, we can thrombolyse that patient. If there is a large vessel occlusion, we can take that patient to mechanical thrombectomy. That's in fact exactly what Dr. Nimji is doing at Ohio State by performing the imaging in the angio room immediately prior to thrombectomy, with the ability then to immediately follow those patients following thrombectomy. An example of patient with vague symptoms, elderly patient presents to the emergency room, somewhat dizzy. This is an older case. Question is it Meniere's disease, labyrinthitis? Is there a tumor or a stroke? In this case, superior cerebellar infarct is clearly documented. Patient can then be treated and handled accordingly. What about post-surgical imaging? So the value proposition here is being looked at by two of our neurosurgical colleagues, Dr. Murat Ganel, chairman at Yale, and Dr. Michael Schulder, the vice chairman at North Shore. What they're doing is utilizing the system in the operating room as an immediate post-operative check. We can see that in the picture here from the Yale OR. They're not using this for neuro-oncologic baseline following a tumor resection, but rather if the tumor was somewhat bloody and they're concerned about the tumor bed, we can get, while the patient's still in the operating room is still sterile and they haven't given it up, get a quick assessment. Is it okay to take that patient to the ICU or not? If it's not, put the patient back on the table, redrape them, and you're ready to go. If they can go up to the ICU, then they go up to the ICU, obviating that need for subsequent potentially delayed CT examination or MR examination. And I think one of the most interesting propositions is that of pediatric hydrocephalus. We are undertaking a multi-site trial being led by Jeff Leonard, pediatric neurosurgeon in chief at Nationwide Children's, along with Dave Limbrick from St. Louis Children's and Barnes, as well as Mark Mittler from Cohen's Children's, part of Northwell Health, North Shore University. And what they want to do is assess the utility of Hyperfine point of care MRI in the setting of pediatric hydrocephalus, kids with known ventricular shunts, questioned shunt failure, and doing it at the point of care. In fact, Jeff has a scanner in his neurosurgery clinic being run by his nurse practitioners. Patient comes in, I have a headache, something's funny, immediately go 2.5 minute scan, can make the determination and diagnosis. The vents are good, the vents are bad. I'll admit the child, I'll send the child home. And this is being done in a multi-site trial, as I indicated. And here's just an example of that. This is a 5-year-old child presented to a neurosurgery clinic. Last known well, normal ventricular size. We can see the ventricular catheter and obviously the obstructive hydrocephalus. There's a FLAIR image, and I don't think I have it here, that shows transependymal CSF as well. Clinical decision can be made at the point of care for treating this patient, obviating the need for even a fast MR scan and screwing up that MR schedule, or God forbid, a CT. Here's another example. This is actually one of Jeff's patients with a 2.5-minute Hyperfine scan in the neurosurgery clinic, confirming the presence of the intraventricular catheter and also establishing or just reaffirming the diagnosis in this child with NF of a tectoglioma and a lesion in the brachium pontus with mass effect upon the lateral fourth ventricle. So as we've developed the system, what we've seen is that our image quality and resolution has progressed over time. Back when the system was first created in 2015, now to where we are in 2020. And a lot of that has been technological advancements in hardware and, more importantly, in software. Most recently, we're using artificial intelligence and deep learning to enhance and improve the image quality without a scan time penalty. This is all done on the scanner without any need for sending anything up to the cloud. What I'd like to do is show you a couple of quick examples before we finish up of the improvement in this reconstruction. This is a 62-year-old patient with a female with a history of breast carcinoma, and we have our conventional linear reconstructed image FLAIR and T2 as compared to the deep learning higher resolution reconstructed image. Realize that this is pending FDA approval. We're hoping to have that approval before the RSNA, but nonetheless, I think everyone can see the significant higher resolution and increased quality of these images with no scan time penalty. There's a slight increase in post-processing time, but the scans are queued up, so you don't notice that till the very end. Another example, a 5-year-old boy with febrile coma and an asymmetric EEG, linear FLAIR, deep learning FLAIR, linear T2, deep learning T2, clearly significant resolution of this cortical edema and cortical expansion and mass effect in this child with cerebral malaria. So I hope that I was able to give you kind of an insight into where we stand with using portable point of care Hyperfine Swoop MR in your clinical neuroradiologic practice. Thank you.
Thanks, Ed. That was a very good top level overview of the potential for this system. You know, as some of you know, I had an early career in MRI development, and we at that point thought 0.35 Tesla was the perfect field strength. I remember UCSF and my colleagues touting that in national and international meetings. That it's kind of like Bill Gates saying all you'll ever need is the famous 64 kilobytes, right? So that prologue is now a history, and here we are going back to the future kind of a thing, going much lower. Of course, some of the earliest systems were at 0.64 and has to do with the resonant frequency, and I won't bore the audience with the physics, but what you guys have done, what this company's done is I think, disruptive innovation, and the disruption isn't to produce better, higher quality images or faster images or a new type of information. The disruption here is really democratization of MRI. Having the tool available in any environment, including the home. We here at Hoag are exploring the possibility of putting this on our vans, and we have a large number of Hoag at home patients, and some of our most frequent visitors to the emergency room are people who have fallen at home, get transported, or are suddenly have a change in consciousness at home, homebound chronic care types of folks, and being able to drive up and do a scan at home without having to transport them to the hospital and find out in a busy emergency room that the brain scan is normal, and shipping them back home is part of the value proposition. So even though I'm a big fan of high resolution, high field MRI, the ability to have something that delivers what you need. Sometimes we let perfect be the enemy of good, and clearly this is good in many, many areas, and provides a value proposition. So Before we open this up to the rest of the audience, and in order to stop me from free associating in my postprandial hypoglycemic state, let's ask the audience a quick poll question. And so let's throw it up there. And so the audience, please make an assumption and assume that the image quality and the deliverables of the machine are as presented by Dr. Knopp. What would your organization consider to be a reasonable price point for this technology? Just choose one thing. 0 obviously means this is worthless. You wouldn't even consider purchasing it or recommending to whoever does purchasing for this technology, meaning, nah, we're not buying this at all. Next is $94,000 a year, an all-inclusive subscription, meaning you pay the company $94,000 a year, no matter how many people you scan, and you can do the math on the reimbursement. Let's say the reimbursement is $500 a patient, and times 250 weekdays or 365. You can all do the math. That's the number of patients you'd have to scan to get the payback, or divide 94,000 by 365, whatever you want, and see the margin, or 300,000 plus maintenance. So 94,000 all-inclusive subscription. It's a subscription model. You just pay the company 94,000 a year, or 300,000 a year plus maintenance, which is typically 10% in the industry. Could you please choose one? And I'm not allowed to vote, but I'm not quite sure how you guys vote. So can someone jump in and tell the audience how to vote?
Sure, there's just a radial button there and you can share your vote. We'll give everyone just another moment or two to answer, and then I can end the poll and share the results with you all.
This is like we should have this as a TV show, right?
We need some music to go back and forth. Like ding, 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 ding. There you go.
Okay.
Kind of like the ASMR Sams, right?
Yeah.
That's right. All right, it looks like the answers have slowed down. Okay, here we go.
Okay, Eddie, there's take that back to the company. There's 6% that say this is worthless. 75% say they take a bite at 94,000 a year, all inclusive, and 20% even say they think the value proposition is there at 300,000 plus maintenance.
That's fantastic.
So let's open that up for questions. Q&A from the audience, please.
Okay,
Sure.
PZ, there's some questions that are written in the Q&A window.
Yeah, I'm having trouble opening my Q&A window. I'm trying to look for it. Oh, here it is. I found it. Okay. Can units be used for other for indications in infants? Can you do body work with this unit in infants?
So the system itself is a dedicated head coil. It's the 8-channel coil, transmit receive, and the sequences are optimized for brain imaging. So while one would imagine that maybe you could, it's not specifically designed that way. Obviously, you're also asking about extremities and joints, and clearly we understand that and are working with R&D sites to look for that, in particular diabetic foot, not germane for the ASNR, but nonetheless.
So I'm going to cut you off, Eddie. It can be developed for body work and extremity work, but right now it's a head coil. Next
Correct.
question. Sorry if I missed this. What Tesla is the scanner? 0.64. So
0.064.
I'm sorry, 0.064. Thank you. So ultra low field is what we would call it. And the cost of the basic system, well, 75% of you said it would be 94,000 a year, all inclusive. So we'll go with that. Eddie, do you want to comment further on the cost of the basic system?
Nope, that's exactly the cost of the basic system. It can be paid up front annually, or it can be broken up in making subscription payments month by month, about $7,000 or so every month for a 3-year term, at which point you renew your subscription, get a new scanner, and start again.
75% of you won the prize of guessing the exact price of the system. Congratulations, and you get a free trip to Hawaii for guessing that. Only kidding.
Good.
Thank you for your interesting presentation. Do you have comparative studies in newborns between Hyperfine and 1.5 or 3 Ts?
So we're actually looking at that, or we are not, but we have clinical partners in the United States at Children's Mercy in Kansas City, where they're looking at it in newborns and neonates in the neonatal ICU and making those comparative assessments. In addition, and some of you may have seen the press release this week, through a partnership through the Bill and Melinda Gates Foundation, they are specifically looking at hypoxic ischemic encephalopathy and nutritional development in infants globally by pairing high-income countries, King's College London, and University of Canada, University of British Columbia, along with low-income countries, Pakistan, Malawi, Uganda, and South Africa. So that work is ongoing, and we're getting that data right now.
Okay, hyperpolarized hydrogen. Someone very astute in the audience must have some inside info. Any plan for hyperpolarized hydrogen IV agent?
So there is one research site in the United States that is actually
That's the guy that asked the question, I bet. Go ahead.
Maybe that is actually looking at that right now, and they just started. They got their system about last month, so I don't have any data on that.
We answered the
polarized gas.
We answered the musculoskeletal question. Will there be a reimbursement difference for doing a study between two? Right now, I'll answer that. Right now, there is none, but the problem with predicting the future is it hasn't happened yet. Plans for RF coils for limbs, we talked about that. Yes, there are. Does the hospital own the scanner at $94,000 per year, or is it's a subscription model? Roland Lee, thanks for being with us, Roland. Nice to hear from you. The question should give more price options or allow us to write our own suggested price point. Roland, you know how to negotiate, so I would leave that to you. But that's the current listed company price, and so see what you can do. Maybe it should be more for you because you asked that question. We'll charge you more, Roland.
300,000. I think that would work.
Roland, for you, it's 300,000. Just kidding, Roland. Nice to see that you're on. Let's see.
There's one question in the chat. You may have already covered that in the Q&A panel.
Okay, so the chat. Do you already have imaging data for acute lacunar infarcts? Can we see acute, within an hour diffusion abnormalities and infarcts, whether lacunar or anywhere else?
I think if they're large enough, clearly the smallest infarct that I've seen is a small motor cortex infarct in a patient from Yale, acutely presented with a left upper extremity weakness. It was in right motor strip, about 3 to 4 millimeters in size.
Nettie, I know you showed some images, but let me ask again. Subarachnoid bleed on flare. Have we?
I don't think we're there yet. I wouldn't put it, if that's the clinical concern, the patient needs non-contrast CT.
Okay. Any other questions out there?
There's one more that just came up.
Okay.
The Q&A about GAD.
Back to Q&A. How does gadolinium contrast interact with Hyperfine?
So utilizing conventional gadolinium like Gadavis, Magnavis, that sort of thing, we can see it on our T1 weighted images if you were to have sufficient concentration. So those patients would have to be triple dosed. Obviously, no one's doing that. That being said, Gerbet has a new product, gadopiclinol, that finished phase 3 trials that was led out of Penn and is now in front of the FDA. We can see gadopiclinol at standard dosage. Gerbet is going to be marketing this as a reduced dose contrast agent because it has very high degrees of relaxivity, but nonetheless, at standard dose, we're able to see the gadopiclinol in an ex vivo experimental model. Once it's available, we can then try it in humans.
Okay, Eddie, I'm going to hand it off to you. I have to run. We actually have our deeming agency doing a site visit, and I'm being called on for presenting to them. I'll let you finish up, and thank you and the video team and to the audience. We'll hopefully see you soon or hear from you soon. Bye-bye.
Thanks, BZ. So I'll finish up whatever questions there are while BZ gets back to work at the hospital. There's another question relates to if we'd like to see this at our facility, how can we do that? Well, since the system is portable and point of care, just like we can bring that system to the patient, guess what? We can bring that system to you, either in a specialized truck that we have that are driving around the country. There are two, one in the east, one in the west, and we can make an appointment to do that, or we can drop off a system, have a delivery service bring the box in and wheel it right into your institution, be it in a conference room, be it in an ICU, whatever that setting is. You can just reach out. I believe that it's on our webpage to do that, or at least contact information is on the webpage to facilitate that. Let's see if there's any other questions. Price points, I can see that. I don't see any other questions. Does anybody else?
I think there's one question about the international availability. What is your
Okay.
international availability, specifically India?
Okay, I didn't see that, but okay. So right now we're FDA cleared and able to commercially sell the product in the United States. We are working for a Health Canada clearance and are almost there, in which case we can commercially sell the product in Canada. There are systems in Canada with an IRB research arrangement, and that can happen anywhere within the world. In addition, we are undergoing UK CA mark as well as CE mark. And I would say it's probably about half a year to a year away for those processes to be formalized, in which case we can commercially sell the system elsewhere. We do have selling partners in the Gulf Coast countries, as well as Pakistan, and an office in the UK. Any other questions?
I don't see any others. There was one about CE marking, but you said 6 to 12 months possibly for that.
Right, that's correct. And in India, again, we're looking at India, along with the other international deployments for commercialization, probably a year away. India maybe a little longer. Anything else? I guess not. Erica, I guess maybe we can give some people back 15 minutes of their day.
I'm sure they would appreciate it, especially those of you joining us from around the world. It's probably very late. Thank you so much, Dr. Knopp, and thank you to Dr. Brant-Sawatsky for presenting this great session today. Did you have any closing remarks you want to make before we go?
Sure. I'd just like to thank the ASNR for hosting and kind of sponsoring this webinar, and to thank BZ for moderating for us. And on behalf of the entire Hyperfine team, hope to see everyone at the RSNA. We will be there in the North Hall. And in addition, hosting an event Monday night. Stop by the booth to get information on that at the Gauge on South Michigan Avenue. So once again, thank you everyone for joining.
Thank you so much. Have a great day, everyone. Bye-bye.